So next up, we're going to talk about healthcare, and we have Jocelyn Samuels, who's the director for the Office of Civil Rights at the Department of Health and Human Services in Washington, as well as George Scangos, who's the CEO of Biogen. So in my prior role at The Economist, I had the pleasure of covering the implementation of the Affordable Care Act and reading massive amounts of the proposed rules that came out of HHS. I know you're in the middle of doing that now on discrimination, but perhaps you can talk us through the implications of the ACA as it relates to LGBT access to healthcare, and then we'll get to you, Dr. Scangos, to talk about what you can do, what companies are doing and can do to promote access among their employees.
Well, thank you, Charlotte. And first of all, let me say how pleased I am to be here and to be sharing this opportunity to talk about HHS's work on LGBT issues. There is nothing more critical than ensuring equal access to healthcare, particularly for communities that have been so underserved in the past. And we are hard at work trying to address some of the barriers that LGBT individuals continue to face in the healthcare space. And I think I probably don't need to tell all of you about the really demoralizing things that LGBT individuals face: higher rates of obesity, higher rates of cancer, higher rates of poverty. The statistics go on, and obviously have a significant effect on access to many opportunities. But in the healthcare space, I think the ACA has made an extraordinary difference and will continue to make a real difference. Among other things, the ACA bars discrimination against people and bars insurance companies from denying coverage for pre-existing conditions, which, particularly for individuals with HIV or AIDS, is a critical new protection to ensure that they can get access to care. Preventative services under the ACA, which are covered without copays or other charges, have to be equally available to individuals regardless of sexual orientation or gender identity. The administration has taken steps to eliminate the prior prohibition on Medicare and Medicaid coverage for gender transition care. And they've opened up things like visitation and made clear that visitation in hospitals has to be available to spouses across the board, same sex or opposite sex. So there are a lot of steps that the administration as a whole has taken. We're also looking to do more data collection. Those of you who respond to or receive surveys from different HHS components are probably aware that we're including new questions about LGBT status in order to be able to collect data that's so critical for getting a handle on what are the health disparities, what are the barriers, where do we have more work to do. But my office, I'm the director of the Office for Civil Rights at HHS, has, I feel lucky to say, a special role in promoting equal access for the LGBT community to healthcare, because we are in charge of enforcing a provision called Section 1557. Sort of rolls trippingly off the tongue, but it's a significant number, because it is the provision of the ACA that explicitly bars discrimination in any health program or activity that gets money from the Department of Health and Human Services on the basis of race, national origin, disability, age, or sex. And stunningly enough, despite the fact that there have been significant civil rights achievements over the last 50 years, sex discrimination in healthcare was not prohibited until 2010 with the enactment of the ACA. It is now unlawful to discriminate in health care or health coverage based on sex, which we have defined to include sex stereotyping and gender identity. We put out a proposed regulation last fall to implement the provisions of Section 1557. We solicited public comment on that, got about 25,000 comments from members of the public, and are now in the process of finalizing that rule. But the proposed rule made clear that we will take a very strong stance against discrimination based on sex or gender identity or sex stereotyping, that it is unlawful under the law for insurers to categorically exclude all services for gender transition care, and that individuals have to be offered treatment regardless of their gender identity and treated consistently with their gender identity, including with regard to access to health facilities. So I think that this law has the potential to be really transformative in continuing to open the doors to healthcare and health coverage, and in reducing the really sorry history of health disparities and discrimination to which the LGBT community has been subject. So I think I'll stop there, but I look forward to your questions.
I'm going to stay with you for a few minutes before we go to the corporate side. When I was covering the implementation of the ACA, I met with a few people who had HIV and had, for 20 years, been without health coverage. And he was signing up for health insurance for the same time and able to get his antiretroviral medicines for a decent price. And so you could really see the effect very clearly there. But on Section 1557, part of the proposed rules, as I understand them, and please correct me if I'm wrong, is that any type of health coverage that excludes gender transition is on its face discriminatory, right?
So I will give you a lawyer's response, which is it depends. If an insurance policy excludes all treatment for gender transition, and sadly we see far too many health policies that still continue to say they will not cover any services related to gender transition, sometimes it's called sex change operations, etc. That is invalid on its face. If a policy excludes particular services related to gender transition, that's something we'll take a closer look at to be able to determine how it compares to the insurer's treatment of the same services for other conditions. So if an insurer, for example, offers coverage for a hysterectomy for whom a provider has said a woman needs treatment for uterine cancer, but does not do so for someone who is seeking that service as a treatment for gender dysphoria, that is a significant problem that we will look at further. We will want to know from the insurer, why are you applying different standards and offering coverage on the one hand for a woman who needs a hysterectomy for uterine cancer, but not for an individual who is seeking it as part of gender transition care. We expect all insurers to offer health coverage in accordance with neutral principles that are non-discriminatorily applied. And to the extent that their assessments are based on old thinking, that gender transition coverage is a matter of coverage for cosmetic or experimental treatments, that will no longer pass muster either as a matter of medical treatment or under the law.
So that was a very clear lawyer's answer, to which I'm going to respond with a dummy's non-lawyer question, which is the ACA has been immensely controversial for many reasons, in part with the health services that are required to be provided through health coverage, through the essential health benefits, right? This is a different mechanism that through discrimination seems like you could get to the same end, i.e., by labeling it discriminatory to not cover gender transition, are you mandating that all health issuers cover gender transition?
And the answer to that question is no. Essential health benefits are a core component of any package that is qualified under the ACA. But beyond essential health benefits, insurers have significant ranges of choices about how they are going to offer coverage for different conditions. That's why it's so important, and we have stressed that people who want to sign up for coverage on the marketplaces look at the different coverage that's available under different policies. So outside the universe of essential health benefits, there's a lot of choice. What we are saying is insurers cannot make those choices on a discriminatory basis. So if they exclude gender transition care altogether, that is by definition discrimination. If they exclude different services for gender transition, we will look at those more carefully to be able to assess whether they are excluding them on a discriminatory basis that is not based on a kind of neutral principle that's applied across the board. Insurers are not required to cover any particular service, but they are required to use neutral principles when they're deciding what they're going to cover.
I'm starting to see why you may have gotten 25,000 comments. But it's a really interesting discussion. I'm sure it will continue as you finalize the rule. But to go to Dr. Skangos, and then we'll return to you in a bit. This has been a priority for Biogen. Perhaps you could outline for us how and when the company's policy on LGBT healthcare sort of began, when you started thinking about this, and how your policies have evolved.
Yeah, it's evolved. It's evolved over the years. Look, let me take a step back. You know, as the CEO, I think it's part of my job, a big part of my job, actually, to set the tone, set the culture for the company. And a big part of what I believe is very important for the company is a tone of inclusiveness and respect. And that certainly applies to the LGBT community, but not just the LGBT community. You know, people can have, let's say, a lack of respect based on gender, based on race, based on hierarchy. You know, I'm the CEO. We have people who empty the wastebaskets. Everybody's a human being. Everybody has a family. Everybody has hopes and dreams and fears. And everybody wants to have some fulfilling life. And I find it offensive if people are interfered with in their ability to achieve those goals because of superfluous characteristics that are irrelevant to their being able to do their job. And you know, in terms of fears, I think the LGBT community has additional issues, right? They face challenges in the workplace and the ability to have a career often, the ability to maybe get a job. That in itself is a health issue. Those are stressful things. And so we have, over the years, instituted a number of policies that I can go into if you want. But you know, looking forward, there's so much more, I think, that needs to be done. You know, we have, I think, transgender discrimination protections should be stronger than they are. You know, I can't believe that in some places people are still talking about conversion therapy for minors. That seems actually kind of barbaric to me. And then issuing maybe more culturally competent healthcare is something I think we need to work on. So, you know, over the years, we've done taken a number of actions, and I wrote them down so I don't forget them all. But in 2004, we had our first domestic partner benefits. In 2012, we expanded anti-discrimination policies to include gender identity and expression. Also in 2012, we introduced new tax benefits to actually gross up same-sex couples in states where their marriage wasn't recognized for tax purposes. We expanded transgender healthcare benefits in 2013. We were early and vocal supporters of the opposition to DOMA and until it was defeated. So we've tried to have a series of policies that are inclusive and make Biogen an attractive place for members of the LGBT community to work, and we will keep working. You know, it's not a perfect world yet, and there's a lot of work yet to be done.
Is it something that you bill prominently in recruitment? How integrated are your policies in LGBT? It is
integrated. You know, we publicize it inside the company. You know, a few years ago in our VP and above level population, you know, we had 2 members who identified as LGBT. That's gone up now, I think, to 7. We have Reach Out, which is our network, LGBT network. That's gone from 2 people to over 300 people in the past couple of years. We've started well, a number of policies. But we poll our employees periodically to see what they're thinking about the company. And after we became aggressive about our inclusion, diversity and inclusion policies, the engagement scores all went up substantially, by over 10%. I think 11% was the official number. So employees like this, not just members of the LGBT community, but all employees, or the majority of employees, think these are good things. They think it makes the company a more attractive place to work and a more inclusive place. And those policies benefit not only people in the LGBT community, but they benefit all of our employees, I think.
So between the two of you, we have sort of interesting examples of the ways in which good access to care for the LGBT community can be advanced. So at Biogen, you're a big company that is self-insured, so you can design your own insurance plan and put whatever you like in it, essentially. With what you're trying to do at HHS, you're thinking about regulations to enforce good practices on a much broader set of the population that's insured. Which are the entities that will not fall under this discriminatory rule? Is it self-insured employees like Biogen? Obviously, it's not applicable to you, but is it all sort of group coverage, all coverage through the state marketplaces, individual coverage? Who does it not cover, if anyone?
So basically, what we say in our proposed rule is that the standards apply to any health program or activity, that's a lawyer's term of art, but it's in the statute, that gets federal financial assistance from the Department of Health and Human Services, whether that is through the marketplace, through the individual market, through group health plans. If an entity that is a health program or activity takes money from the department, it does so on condition that it agree to abide by these non-discrimination standards. This has a long history in anti-discrimination law, and starting back in the Civil Rights Act of 1964, there was a prohibition on race discrimination by any entity that took federal funds. And the premise of it is that government money, taxpayer money, cannot be used to subsidize discrimination. And so any entity that takes it has to abide by this range of non-discrimination protections. The new thing about Section 1557 is that, as I said, before 2010, there wasn't that kind of a prohibition on sex discrimination in healthcare. And I think that is one of the things that's truly transformative about the law, that entities that had already been subject to prohibitions on race and national origin and disability discrimination now have new responsibilities to avoid discrimination on the basis of sex. Now, I will say, entities that are not health programs are not covered by our rule. So, for example, the Department of Health and Human Services funds a range of human services activities like child welfare agencies, TANF benefits, other kinds of social services, and Section 1557 doesn't extend to those entities. So it is a more limited protection than is available in other contexts for race, national origin, and disability discrimination, but we are firmly committed to ensuring robust implementation of it in the healthcare context.
So the Affordable Care Act was passed in 2010. This rule was proposed at the end of 2015. I know there have been a lot of things. A lot of things have been going on within HHS over that time, but is it because there was a lot of controversy around what this rule should contain? What's the reason for the 5 years?
So let me make clear that Section 1557 has been in effect since 2010, and one of the enforcement mechanisms that we use under it is to take complaints and investigate them and reach resolution agreements with entities that we've found have discriminated. That work has been ongoing since 2010. While the regulation has been on a slower path, and it always takes more time than anybody would like to get these government regulations out the door. But I would say we see the regulation as confirming standards that we have been applying in our complaint investigations. And our hope is that it will be a very useful way for entities that are covered by the rule to understand what their responsibilities are, and for individuals to understand what their rights are so that they can advocate for themselves in dealing with the healthcare providers they encounter.
So I'm going to ask one more question, but the audience, please do get your questions ready, because I'll turn to you immediately after. But on Truvada or similar therapies, this idea that there are drugs available now that can be used prophylactically to prevent the transmission of HIV. What is the appropriate coverage? Is it something that's covered under Biogen's plan? Is it something that is or is not covered, required to be covered under the essential health benefits or through Medicaid? Maybe we could, if you wouldn't mind both just touching on that.
I actually don't know. That's a good question.
You don't know the ins and outs of your health insurance
of all the details?
Coverage plan?
It should be.
Yeah.
I will say that. I actually don't know if it is or is not. But look, let me follow up on one of your comments here, which is that government moves slowly, right? And cultural change occurs slowly. And so there's a gap, the time gap between where we are now and until we don't need programs like this anymore. So I think companies like ours have a role in helping to bridge that gap, and that is by starting at home, taking care of our own employees and making sure they have appropriate healthcare coverage and are treated equally. And once we do that, then we have standing to encourage other organizations with which we interact, suppliers and customers, to enact similar policies, which we also are doing. So I think there's a role for, obviously the ultimate goal is for government to mandate these things. But until that happens, I think we have a role to play in bridging that time gap. So.
I'd say a couple things. The first is, we are an enforcement agency and we will take enforcement action where necessary, but it is always our preference to promote voluntary compliance and to enable entities to take the right steps because they understand their responsibilities and are committed to non-discrimination. So if there are ways that we can provide technical assistance or help in understanding what the requirements of the new law are, we are happy to do so and happy to hear from you about that. With specific regard to Truvada and other drugs, there have been all kinds of coverage and complaints recently about insurers that choose to put all drugs for the treatment of HIV and AIDS on their specialty tiers for coverage of those drugs. And I know that, for example, in Florida, there have been various complaints that were filed, and insurance companies there have been forced to change their policies. We are looking at that issue because, again, if you make drugs for treatment of a particular condition too expensive for people to be able to afford them, then the nominal coverage that you're offering is not a reality, and that can operate in as discriminatory a way as barring them altogether. So these are issues that we would look at.
So any questions from the audience? Yes, right here in the front. Someone will bring a microphone to you, and please do say your name.
Hi again. Lizarn McAllister from Accenture. In other countries, and this is something my eyes were open up to, many other countries, the term is not LGBT, it's LGBTI. And we don't really include it so much in the US and include the I, standing for intersex, in the community. And there's a lot of talk globally around whether I is a part of the community or not. And a big part of that is around benefits and, how do we take care of those who are born I and, who represents those people even when they're not grown, they're children, because often that decision is made for them right after birth. And I've heard statistics about there are more eyes born in the world than those with red hair. And so I wanted to know from your perspective, from a civil rights perspective, what you think about that. Does your department look at that for those who have had the choice made for them but are experiencing body issues, especially as they hit puberty, as they get into adulthood, they start to experience things or they may identify differently as I, not F or M. And in the workplace, it's becoming an issue or growing as an issue. What is your perspective on that?
So we intend a broad definition of sex discrimination. Of course, under our rule, in order to have a claim under our rule, someone would have to be subject to discrimination in health care or health coverage. So what we said in the proposed rule is we are not addressing, for example, employment discrimination by healthcare entities. That's something that other federal agencies address. We have limited jurisdiction to look at discrimination in employee benefit plans. But we have gotten a lot of comments through our rulemaking process about the appropriate definition of sex discrimination, and in particular, how gender identity should be defined, whether people with non-binary gender identities are intended to be included, whether intersex people are intended to be included among those protected from discrimination on the basis of sex. We will be addressing those issues in the final rule, but I would say I think that it is a core component of sex generally to think about what your biological sex at birth is, and then as to gender identity, what your self-identification is, and we certainly mean to cover discrimination on both of those bases.
Any others from the audience? Really, I have so many questions left to ask. Oh, well, okay, go ahead. We'll have the microphone come to you again. And this will be our last one, so you'll have the last word.
Okay, if no one else has questions, all right. So I know you talked about entities who take money from the federal government. I don't know if doctors are necessarily included in that. But if they are, is there thought around the education of doctors when it comes to transgender benefits or gender reassignment, and how to both evaluate, care for, and so on and so forth? I have heard stories of many who have spent money just on travel alone to get to a knowledgeable doctor who can give them the correct information and properly take care of them as they go through their transition. It's not a direct discrimination, but it's a disparate impact in that if your doctor doesn't know anything about what you're going through and that's a part of what their job is to take care of you, how do you deal with that? Also,
and just to add on for one moment, every doctor in America receives money from the federal government. There is no doctor that I'm aware of, I mean, it's very, very, very small, who doesn't get money from Medicare, Medicaid. I mean, it just doesn't happen. So presumably this rule.
East Side.
Pardon me?
I said they're all on the Upper East Side.
Yeah, exactly. That's true. Even there, though, I mean, they
if they
take a little bit.
Meaningful use money, or
yeah, I mean, there's some money there, but to your point, yes, that is correct. But so this rule should cover every doctor, presumably.
Yes.
And just I'll leave you to answer this gentleman's question, but for how do you deploy that kind of training on such a broad level?
So, let me just affirm what Charlotte said, that virtually every doctor in the country gets some kind of money from HHS through Medicaid, through Medicare, through meaningful use payments, through other kinds of benefits that we provide. So I think as a general rule, I would be hard-pressed to identify medical practices that would not be subject to this rule. Similarly for hospitals. skilled nursing facilities, nursing homes, long-term care facilities, et cetera. With regard to an education campaign, I think what you say is incredibly important. I think, as George said, some of this is a matter of society coming along. We will do everything we can once our final rule is released to go out and educate the medical community, hospitals, providers, medical students about the requirements of the rule. We are not capable of telling doctors how to offer medical treatment. That, I think, is the role for medical schools, training programs, residencies, and I do hope that over the course of the very near-term future, schools and hospitals and other educational programs will start offering more training about how to meet the health needs of this growing community. And that's something that we'd certainly be happy to support in any way that we can.
We're going to have to leave it there, but thank you so much to Jocelyn and to George for that really interesting discussion. Thank you.
Thank you very much.
Thank you so much. Great to have you.
Pleasure.
Thank you. Thanks so much.